This is the second part of a two-part lesson. If you haven't already done so, you're also urged to navigate through Evidence-Based Respiratory Care Practice in the NICU, Part 1. Smalish and co-workers, in a study described in Pediatrics in 2012, suggest that some of the respiratory deficits observed in VLBW patients with BPD might simply be attributable to their small size. When they adjusted for birth weight, the differences between the peak expiratory flow rate, or PEFR, of 29 BPD infants of VLBW and a cohort group of 26 VLBW babies without BPD was not significantly different. The completion of this study, of course, required that these researchers be able to measure PEFR in the first place. This posed an imposing challenge, because not only were the patients so young as to be unable to follow commands, but in addition, it was required that they be sedated beforehand. How, one might ask, can anyone elicit a forced expiratory effort from a sedated baby? Perusing this monograph equips the reader with insights that she or he might never have acquired from another source. Mandy Malkar and colleagues were interested in determining the optimal timing of tracheostomy for babies with BPD and reported their findings in Pediatric Pulmonology in 2012. They studied a group of 22 babies for whom tracheostomy was performed at a mean age of 177 days. They were especially curious whether or not high ventilatory pressures should be considered a deterrent to the placement of a trach, and on the basis of their research, they were able to determine that high PIPs need not be considered a contraindication. All clinicians who practice in a NICU are vigilant about the deleterious effects of hyperoxia on the retinal vessels of preemies. But the next research paper considered is a comprehensive and authoritative review of the effects of hyperoxia on the respiratory tract by Vineet Bhandari, a noted scholar from Yale University. This monograph, published in Seminars in Fetal and Neonatal Medicine, is included to reinforce our awareness of the perils of hyperoxia in preparation for our consideration of a specific population of patients in whom hyperoxia is virtually obligatory: DCD neonatal organ donors. In this and only this subpopulation of premature infants, RCPs should ensure that the lungs to be donated not be damaged as a result of the 5 to 10 minute period of apnea that is undertaken after life support is discontinued. This period of apnea in turn is required in order to identify the infant donor as a suitable candidate for harvesting. Most of these infants are so-called brain-dead or heart-beating donors, but some are non-heart-beating donors who classify as, quote, donors after cardiocirculatory death, unquote, or DCD. It would certainly be tragic if the donor organs were to be damaged during the 5 to 10 minute period of apnea that is imposed in order to confirm death. Consequently, a 7-minute period of ventilation with pure oxygen should precede the apneic interval. This antecedent period of hyperoxia ensures that the organs that will be harvested will be suitable for transplanting. In order that the learner be made aware of the necessity to deliver pure oxygen for 7 full minutes, the monographs of Howe et al. And of Schurter and co-workers are examined. Their studies verify that the delivery of pure oxygen for at least 7 minutes is sufficient to fully denitrogenate the alveoli and protect harvestable organs from tissue hypoxia. In the subsequent research investigation that appeared in Pediatrics, Geary, Caskey, Fonseca, and Malloy report how their use of surfactant, nasal CPAP, conservative oxygen saturation goals, and early amino acid administration succeeded in substantially reducing the incidence of BPD in their NICU. Next, the module examines an urban myth that is quite widespread among NICU practitioners: the belief that the incidence of tachycardia is high in the wake of albuterol administration. Dr. Fahim Korfand and her intensivist co-workers published the results of their study of 70 critically ill adults in CHEST in 2011. In a series of 836 aerosol treatments administered to sedated, mechanically ventilated subjects, the observed incidence of tachyarrhythmia was 0.6%. Ventilator asynchrony is an all too common disorder in the NICU, and the following paper published by Alander and co-workers in pediatric pulmonology compared the effects of flow triggering, pressure triggering, and NAVA triggering in ventilated NICU patients. In this crossover study, NAVA was found to be significantly more effective in abolishing asynchrony than either of the other two modes. One of the most welcome and striking attributes of NICU teams is the collegial bonds that are forged between its interdisciplinary members. That means that you get to acquire a whole lot of knowledge from your physician and nursing colleagues. But it also means that you're expected to contribute credible clinical information to the rest of the team. Using these modules to enhance your current mental archive of evidence-based knowledge will enable you to enrich the knowledge base of your entire team.